poner la cámara. Ahí está. Me parece la bolsa. El problema es que quedamos de costado.
Hello, my friends.
Hello, doctor. How are you?
Hello, how are you? How is it going? Everything is okay?
When would you like, we can start.
Yeah, feel free. You have time to check it, but in this direction, the screen is completely okay, and I can see your laptop very clear.
It's the only way to do this. We prefer
Okay, no?
to do by Zoom, but it's okay.
Yeah, we tested the stream live, but there were some problem because I wasn't able to join your live, so we have to continue in this manner. No problem.
Okay.
Thank you.
Okay. We prepare to start.
Okay, let me. I just want to start this session and say I'm very delighted and very thankful that you have accepted our invitation to the ELS program, and this is a great honor for all of us that we can have the chance to learn from you. The topic of this session is the Beyond the Apex with Licon-D. If I have any spelling or pronunciation problem with the material, please correct me. This is actually the sixth or I think the seventh session of the ELS program, and we hope we can have the same programs and same shows in the near future, and this is just a prototype of what we are going to do together in the near future. Thanks for accepting our invitation, and you can start your presentation. I'm all ears. If you want, you can present yourself and give us a brief explanation and introduction about yourself, or you can go to start your presentation. It's yours.
We are working at the Ateneo Argentino de Odontología at the clinic, and we do this at the work. Yes, I'm Lucas Matías Gaona, and the doctora Janina Rola. She started the presentation.
Very good.
Well, first of all, we want to thank you for being on the other side, especially at the people of the Endo Show for giving us the opportunity to do this live and allowing the way of we working. Well, like the doctor say, the topic we will discuss today is how to achieve the regeneration of lost tissues through endodontic therapy, using a biomaterial designed for that purpose. But first, let's define some concepts. When we talk about an endodontic treatment, especially in those cases where there are huge periapical lesions, we face challenge that we must overcome in order to achieve success. And what are those challenges? As we can see in this microtomography that we have here, we see that the interior of the tip has a great interconnection between the canals through lateral canals, intercanal, secondary, and a lot of possibilities. This complex anatomy poses a great challenge for cleaning and shaping, of course. As we also observe lesions like this, the presence of a very complex and organized bacterial flora. This is very difficult to combat. This is how we can define the two main problems to combat are the infection and complex anatomy. That we want to do for make the better endodontic treatment. As we see in this other photo, the great anatomical variability and the complex interconnections between the canals. Here we can see here too, Here, we can see at the apical level the presence of multiple foraminas in the same root, of course, which not only poses a problem for us at the time of filling, but this anatomical complexity, they have millions and millions of microorganisms which we must neutralize to gain a final success. So, to exemplify that, we have this, put this microtomography in which we see this is a scanning of a gutta percha point, and that we can see a lot of microorganisms present in this point removed from the periapical lesions. So, but with that, we deal with daily in our office. We have two treatment options that constitute the called endodontic schools. One, we have the concept of instrumentating, cleaning, and obturating up to the established working limit, leaving the organism in charge. Living in the organism in charge fighting the infection, called the mechanicist school. And we have this what is we call regenerative or structuralist school that consists of actively intervening at the site of the lesions, exceeding the apical limit with a biomaterial intended for that purpose, which collaborate to fight the infection and stimulate tissue regeneration. And why this is important? Because we want to achieve tissue regeneration and not just repair. And what is the difference between these two concepts? The fundamental difference is that in the case of repair, the lost tissues is replaced by another with similar characteristic, which restores the lost form, while in regeneration, the damaged tissue is replaced by exactly the same tissue and existed previously, thus restoring form and function. And it is what we want to achieve. Let's understand the regeneration. With regeneration, we obtain the same tissue before the damage. And how are we going to achieve this? For those who don't know, I present you Dr. Oscar Maisto, who is considered the father of Argentine endodontics, who in the 50s and 60s already exposed this concept about regeneration and how we can influence and stimulate the organism to achieve safe regeneration. In words of Maisto, to achieve repair of the tissue at the periapical complex after tissue injury, it must be stimulated and influenced, overcoming two main factors, like we said, infection and complex root anatomy.
Wait, sorry. The doctor said this at 1967. Yes, sorry.
And how are we going to influence of regeneration? One of the ways is by micromolecular stimulating cells responsible for tissue new formation. And how we can do this? Through the use of a biomaterial. And what is a biomaterial? Biomaterial is a material that replaces living tissue, whether pulp tissue, dentin, or the dental insertion system, when it is accidentally or intentionally invaded for therapeutic purposes by a bioactive, resorbable alloplastic system, intended to positively modulate the body's self-repair capacity. And regenerate apico-periradicular tissue in lesion of endodontic origin. In short, biomaterial is one of these is designed to interact with biological systems. And we have three types of biomaterials, according to European Society of Biomaterials. The first generation was considered inert and non-resorbable, for example, gutta-percha points. The second generation, once they are resorbable and bioactive, this is to say that they interact with the tissues, and the third generation, ones that in addition to interacting with the tissues also influence their function, for example, by stimulating the synthesis of a certain substance. The only third generation biomaterial for endodontic use is Licon-D. It's a filling material in paste form. It comes in presentation like this. But what does Licon-D means? It stands for control drug release, and by drugs we mean the release of essential ions to positively influence tissue disinfection and regeneration mechanism. It's composed by zinc oxide, iodoform, thymol, calcium alginate microscope, camphor chlorophenol, and anhydrous lanolin. The principle of action of this material is the release of calcium, iodine, and zinc ions, but in a controlled and sustained manner for a period of time. This is how iodine ions will help fight the infection, and calcium will help with new bone formation. The main characteristics of this material are modulate the reparative response in the dental attachment systems, inhibit bacterial growth, working hand in present parity with the bone repair process. This is very important since when it's slowly reabsorbed, it allows the ions that compose it to be released in a controlled manner at the moment when the body needs them. This is how at first, by releasing iodine and zinc ions, it collaborates with the elimination of the infections, and later, with the release of calcium ions, it intervenes in the process of new bone formation. In summary, the action of each component is iodine, bactericidal, summons PMN, intervenes in the myeloperoxidase pathway, calcium, trophic factor, anti-absorptive and bone formation stimulator, and zinc, antiseptic and stimulating immune response. So, the two main pathways of action of this biomaterial are modulating the reparative response and inhibiting bacterial growth. Modulate the reparative response through the action of calcium and through the influence on the rank OPG, rank L system, and inhibiting bacterial growing through the iodine ion. But what is the therapeutic action of the iodine ion? Antiseptic action, great terminal capacity, broad spectrum, acts on gram-plus, gram-less spores, fungi, and viruses. Penetrates the bacterial cell walls, reacts with fat acid, altering the property of the lipid membranes. These last 2 points are responsible for its action and eliminate the infection. In addition to its activity as a necessary ion in the ionic pump responsible for the destruction of bacteria in the phagolysosome through the myoperic pathway, which is the body was the way of destroying and eliminate some anaerobic bacteria. This is what is exemplified in this slide. Bien. I will briefly review the action of calcium, as it is a very complex topic to discuss in depth today, but to make it clearly how it intervenes in bone neoformation, there is a system called rank of G, rank L, which under normal condition regulates bone homeostasis. As well, we know the body is constantly renewing our bone system through resorption and neoformation process. What's this process? Here we have the osteoclast. The osteoclast has receptors called which when they bind to the so-called rank L, generate the activation of the osteoclast, thus activation the bone resorption process. This resorption process stopped when the protein called osteoprotegerine in that slide, that's the osteoprotegerine, intervenes in the environment, which bind to the ligand, preventing the union of this with the osteoclast, producing apoptosis and the end of the resorption. This protein is synthesized by osteoblasts in the presence of high quality of extracellular calcium, like anti-absorb or anabolic factor. That is the reason for the inclusion of the calcium ion in the filling material. This is how we manage the influence molecularly the new bone formation using the same ions that the organism uses in normal conditions to sustain exactly the same tissue before the injury. That's why we speak of an ad integrum regeneration of the tissues and not a just repair. Well, I hope I have not bored you too much with this concept. I know it's a lot of new concepts, but they were necessary to understand the action of the material that we are presenting to you. Next, Dr. Gaona Lucas will talk to you about the manipulation of the material, how it's used, and at the end, he will show you a series of clinical cases and their follow-up treatment with this material.
Well, this part is heavy, but we pass quickly. And we answer, what is the rheology? The rheology is the branch of physics that studies the flow and the formation of fluids. Yes? Particularity, focusing on their mechanisms, properties such as viscosity and elasticity. Understanding rheology is crucial when assessing the behavior of biomaterials. For example, Licon-D, which is initially present as a paste and solidified due to the rheological property, is a non-Newtonian fluid. The technique to filling the Licon-D paste is straightforward. A small amount is taken from the bottle with a spatula, placed on a glass tile, and gently pressed. Next, we'll see the video. Until a free consistency is achieved. If necessary, para monoclorofenol alcanferado can be added. Yes, it's important to note that paste doesn't undergo a herling period. Instead, it solidifies out and manipulation specifically by apical compactation. Okay? Here we see the way we can fill in the Licon-D. by apical transforamen, by a fistula, and a periodontal pocket. In the next video, we can see how Eduardo Fernandez Monge show us at the manipulation of a dental laboratory tooth. I'm going to advance a little bit because it's too long. Here he this is the Licon-D, de paramonoclorofenol alcanforado. Here is spatuling. And we next see how take a little part of the material. The pass is then introduced in the column using a smile file smaller than the last instruments used. The material is taken on one side of the file, and the free side is placed again at the opposite wall to deposit the biomaterial. Using a counterclockwise motion, or the Archimedes screw principle, the material is placed and compacted apical, and we say, Eureka. Okay, next. Bueno, now let's to move to the clinical case, which has a particular interest. The first case is a trauma with a significant periapical lesion in a 11-year-old child. The case was manually instrument, irrigate weights, 1% iodine solution are overfilled with biomaterial, completing the obturation with the gutta-percha cones. The apical plugs were made 2 or 3 millimeters in length. Postoperative follow-ups at the 2 months show the horizontalization of the biomaterial. After 12 months or a year, complete tissue regeneration was observed. Yes, we can see how the biomaterial horizontalization. The next case is also courtesy from Dr. Eduardo Fernandez Monge, who concerned an endoperiodontal lesion where tooth 4.7 exhibit significant mobility and the vestibular fistula. The endodontic treatment was performed manually in 1 session using the iodine solution for irrigation, followed by instrumentation and obturation with Licon-D. Intentionally overfilled to follow the path of the fistula. Here we can see he filled the Licon-D and continue the fistula. Yes. Follow-up exam show the material horizontalizing as needed. Here we can see the fistula disappear. And after 4 months and 44, that means that the occurred regeneration, yes? Next case, we can see preoperative lesion with a fistula, and here we not a fistula. Yes. This case involves the retrainment of tooth 2.1 performed using mechanical endodontics irrigation with a 1% iodine solution was followed by sealing with Licon-D. Pre, the subduration and conductometry, postoperative, immediately, control at the 15 days. We can see how the limits of the obturation. This case involved a retrainment certificate that had a particular challenge of a large cast-out post. Yes, acá en Argentina decimos, here in Argentina we say perno pasante. In English, as a large cast-out post, which require carefully removal without damaging the tooth's anatomy. The endodontic procedure was performed using mechanical techniques, followed with irrigation with a 1% iodine and obturation with Licon-D in one session. The subsequent control exam at 15 and 30 days. And we can see the limit of duration is determined by the organisms. We don't determine the limits at the finish of endo. The limits is determined by the organisms. Yes? The next case. The next case is provided by Dr. Edgar Carrillo, illustrate the use of Licon-D in a mechanical endodontic pressure, yes, with a radix entomolaris, and we can say the horizontalization of the biomaterial. In the X-ray imaging, we can observe how the biomaterial behaves at the presence of lateral and collateral delta apical and accessory canals, identifying the main canal, and the X-ray can be challenged. Yes? This case involved a patient who had undergone root canal several years early with a dentatus and acrylic crown. The tooth exhibits side mobility and a fistula. The root canal was treatment irrigated with 1% iodine solution and intentionally overfed in one session. A fiberglass post and restoration were placed, and follow-up exam at the 16 days showed noticeable improvement in the periapical tissue. Yes? 45 days at 60 days. We can see new bone. This is regeneration. It's not a repair. Regeneration. Yes? This is a case of trauma, filling with Licon-D, and we can see at the 30 days how the biomaterial is horizontalizing. The next case is another contribution for Dr. Carrillo, where external dentin resorption was treatment and completely fixed with Licon-D. And what we think? If resorption continue, the biomaterial behind consciently with a filling limit determined by the body rather than by an anapical stop. In contrast, if a traditional cone and cement technique have been used, a Grossman subject 15 years ago, the cone will have caused a trauma to the apical tissue. The same behavior is observed in a internal dentin resorption. It's okay? You understand? It's fully Licon-D. If the resorption continue, the Licon-D acompaña. Accomplish. Okay? the same as reabsorción dentinaria interna.
Internalization.
This is a case simply of necrosis, mechanical instrument with the 1% iodine solution irrigation protocol, maintaining permeability, apical plug were made with Licon-D, followed by the obturation at the same paste and Guccia-Percha point. A check after 15 days showed the material horizontalizing and the apical closure before achieved immediately post 15 days control, horizontalizing the biomaterial. And this is of my favorite case, as he offered a comparison of different technique and the material behavior of the same tooth. When an upper lateral incisor represents to the clinic, it generally causes for optimism. However, upon refer, I suspect more than complex issue. So I request a cone beam CT scan, and here we see a large lesion with bone vestibular here, loss, and the vestibular side, and two rods, a mesial rod and distal rods in a lateral incisors. It's not impossible to perform obturation with a sealing cement technique. The distal canal presents no such issue and was instrumented with a single file reciprocating system. This canal was obtured with Licon-D and Guccia-Percha cones or points, with the apical plug measuring 2 and 3 millimeters, followed by Guccia-Percha and the paste. The mesial canal, unable to determine the working length and lacking an apical stop, we fully fill with well-compact Licon-D, with the body determining the limit of duration. Here we can see the oversized past of Licon-D at 3 months, how the body determines the limits of the root canal, and 10 months later, we can see how is the biological apical close. Here we can see pre-operative and post-operative. Yes. Well, to conclude the case, we have soon chosen to share today, although there are many more. None of the would be possible with the support of the team of friends. Here is me. Here is the professional Dr. Jorge Fernández Monjes, doctora Laura Charuquian, doctora Mabel Ortega, profesor doctor Juan Mer, doctora Janina Rola, doctor Eduardo Fernández Monjes y el doctor Edgar Carrillo. We warmly invite to your visit our country and experience all its wonder. If you have any question, please feel free to research out to us via Instagram, as communication may be slow due to the delay. We're happy to send you all the scientific articles to support our work. Thank you so much for considering us, and don't hesitate to contact us. Here we stay with the chef of Jorge. Here is the inventor of Licon-D, one, or chief of the clinic. Yes.
Very good.
Esperemos que se haya entendido algo.
We hope you understand.
Nice to meet you.
Nice to meet you.
Nice to meet you. Thanks for coming to our live. It's an honor to have the chance to have you in this show. Very impressive presentation, and I really enjoyed the cases, and I really thankful for the cases and for the knowledge you shared to us. It was very impressive. I have many questions, but this is a great chance for us, I think, to ask the questions. If you have finished your presentation, we can go for the question. If you are okay with that.
Yes.
Okay.
We're the boss to respond the question. Yeah, we boss.
Yeah. The inventor can answer many questions because we may not have the same chance in the future to have the inventors and the manufacturer of this product in front of us. Okay, I have some question. My first question is about the obturation technique. I saw that you have used two different techniques in order to use Licon-D in your cases. The first one is, I think, using a gutta percha and Licon-D in order to use them together. For example, you can use a single cone technique with Licon-D. And
No.
but my question is there any possibility to use Licon-D with the gutta percha as a single cone technique, or we have to fill the root canal system completely by the Licon-D?
No. No, con condensación in English.
Sí, lateral condensation. We don't use a single cone because this material is not adhesive.
No, not adhesive, no.
Sí.
Y hace un tapón de...
Sí.
We...
The technique is make a apical plug and the rest of the interior of the canal is saturated with cones, with gutta percha points, and the material in a lateral condensation. We don't use just single cone.
No.
Okay.
In many cases, here you see I use the gutta condenser because you do with Licon-D 2 or 3 millimeters apical plug, and this permit you condensation heavy.
Yeah, you have to use it for the apical plug. Yeah.
Without apical plug.
Very good. So you can use Licon-D in order to have apical plug. It's very impressive. About the consistency of the Licon-D, is there any recommendation by the manufacturer?
It's a past. And you spatulate heavy, makes it heavy by the Archimedes screw principle. You hard the material in the interior of root canal.
It can be the same as, I think, MTA-like materials. It can be, I think, the consistency is something like MTA-like materials. If I'm right or wrong, please correct me. The consistency is
no, it's a past. It's a past.
It's different?
No. Yes, it's different.
Two different consistencies. When you see in the video, first, it's like a past strong pass.
Yeah,
when you mix
the paste.
When you mix it with the monochlorophenol, you make a dilution, some kind of dilution, and it's like another cement, like we used, the consistency.
Okay, got it. Yeah.
The radiology determines hardness the biomaterial.
And for pressure.
Yeah, it should be in a actually consistency that you can pack it in the root canal system.
Yes.
Okay.
Yes.
Very good. And I have the question about the retreatment possibility of Licon-D. Is there any solution to dissolve this material? Because, for example, you may have some cases that have the failure for any reasons. Is there any possibility to remove the Licon-D from the root canal system by any material or any instrument? For example, is it possible to remove the Licon-D from the root canal system by the K files or rotary files, or we have to use, for example, a dissolution material, for example, like chloroform?
Yes.
Yeah. It's like any other cement that we use in endodontic. You can make this obturation, and if you wanna subturate the apical plug, we use paramonochlorophenols, that is the salt.
Okay, but so it has
You
a
can
dissolution
completely.
completely. We can dissolve it from the root canal
You
system
wanna
completely.
do a retreatment?
Very good. Okay, my next question is about the setting time of the Licon-D. Is there any time specific that is determined for the setting time of the Licon-D? For example, how long does it take to be completely actually set? For example, for MTA material, we have 4 hours of setting time.
No.
Is there?
It's hard by work. Under pressure, the biomaterial hard. You understand? This, the rheological prospect is this.
Can you tell me, for example, a time, for example, 2 hours, 3 hours, 4 hours, or it is just
No, at the work.
set immediately
At
after?
the work. At the work, the biomaterial.
No, it's hard.
It's hard.
But
At the work.
Pressure.
Under pressure.
Oh,
if you leave
you
it
mean when you
yes,
you have
you mean
a lot of work of time.
you don't have a time to fill sealing a root canal. You have a lot of time.
So the working time is very wide and expanded, but about the setting time, how can we be sure that the Licon-D is completely set? For example, when you use bioceramic sealers, if they don't have any contact with the water, they won't get set. And my question is about how can we check the hardness? Is it possible to check the hardness and the final setting of the material or not? And about the time, for example, after 3 hours, we can be completely sure that the material is set. Or I think you said that when we put the pressure on the material, it will be completely set immediately. Question is about this.
Immediately, you can do the restoration of the tooth. Immediately, clean the root canal with its alcohol, and you can do the technique, the restoration at the moment.
So there is no need to wait for the final setting of the Licon-D. Very good. Very interesting. And my question is about the difference between the Licon-D and other materials. What are the main advantages of this material over other materials? For example, some may argue that we have bioceramic sealers and MTA-like materials. What is the main advantage of this material over the material itself?
The first characteristic of this material is you can throw past the apex, and the material is not dangerous. Don't make a response of the organism, because it's prepared to change ions between the extracellular spaces, and that's the why they make the resorption. I don't know what you mean.
Yeah.
It's safety because they have the release of calcium and iodine, the principal components, but it's not immediately. The other materials in endodontic release, example, calcium, DMTA, release calcium, but in a period of 24 hours. After this, don't continue releasing the ion. And the property of this material is the long-term release. It's for time. It's a continued release of the calcium. When you see the radiography and the 15 days, you can see the material gone. Now, the material is making a change with ions of the medium, and that's why we can see in the radiographic, but it's still acting. That's the action.
Very impressive. My question is, how can we be sure that when we put this material in the root canal system, it may not be dissolved in the long term? For example, when you use calcium hydroxide in order to put a medicament in the root canal system, you will see in the long term that the material will be gone because of the contact to the apical, for example, any water or any actually material in the apex. How can we be sure that this material will not be dissolved in the long term?
The difference is the consistency of the material. When you throw out of the apex, this material is not hardness. You just put it on the lesion. But when you make the obturation, you hardness with pressure. And when you do the lateral compactation with the gutta percha points, you hardness to the rest of the material. So the part of its hardness is not resorption. Resorption, the free in the lesion.
So you mean that
for the consistency.
Sorry, this determine the OPG rank.
No, no. That's
Sorry.
Okay, no problem. I got the point. You mean that as long as it is in the root canal system, because of its hardness and it is compacted in the root canal system, it is not. It can be dissolved in the any actually.
That's the difference.
Yeah. But when you push the material beyond the apex because of its consistency, and it is actually very flowable, and you can say that it is now it can be dissolved and dissolved by the body. Very good, very interesting.
That's the reason why.
I like the idea behind the inventors and behind the actually inventing this material. Very good. My final question is about the articles and the evidences we have in the literature about this material. As long as I have searched for the articles and the papers in the literature, I just found one article which was published about this material. I want to ask you if there is any other article in the literature. Can you introduce us, or we have to wait for the future articles and the papers that will be published soon?
Yes, the Dr. Fernandez Monjes wrote a book that's the name Biomaterials
of use and endodontic use.
Of Indian endodontics use, and he have 14 years old of investigation.
There are a lot of papers and scientific articles of this.
We share you.
We can share you.
Yes. By the Instagram, the WhatsApp group, and you share at the Instagram.
These articles are about the Licon-D or not?
Yeah. Licon-D and
Licon-D, iodine use.
Very good.
A lot.
Clinical cases, a lot.
14 years of articles.
Very good, very interesting.
One of the cases of the doctor showing is coming soon to publish.
Very good, very good. It's a case report.
Yes.
Published in a case report article. Very good. And I want to ask you if you have any test or any histological examination, because you have talked about the regeneration and repair. Regeneration and repairs are actually histological terminology, and we cannot say that we have repair or regeneration by just looking at a 2D radiograph or any periapical radiograph. How can you be sure and you can claim that the type of the repair is regeneration?
El artículo
There is
Smeller.
a scientific article writing by Smeller. It's called the doctor who writes it, and he having this article all the
rat. En la tibia, en la tibia la rat.
he
Phil. Phil. Puso.
Sí, pero comprovation. That makes the comprovation histologically of this.
So we have
I can share the article.
Yeah. So we have articles that have tested the outcome of this material by a histological examination. Very good.
Yes. Well,
very good. I have asked actually all of my questions. Let me check the comments of the audiences if there is any question or not, and then we can go for the final part of the session. Okay, it seems that we don't have any other questions. Very well. Thank you. Thanks for your great presentation and your dedication toward this session. It was very actually insightful for me and for all the audiences. This was the first time for me that I have the chance to get familiar and to learn about the Licon-D material. And I think that we will hear more about this material in all the dental market around the world in the near future. And we are looking forward to the chances and to have the opportunity to use this material in our practice. And I want to have this material at my clinical setting to check the outcome of using Licon-D in endodontic cases. I was very impressed, and I want to again thank you. Thanks for accepting our invitation, and we will do more same projects and different actually program with you. This is just the beginning for our journey. Thanks for everything. If you have any comments or if you want to talk about any important issues, you are free.
Thanks.
Thanks for giving us the opportunity of showing this material.
If any question, send us.
Okay, maybe any question, or if you wanna, we can show the articles. Send us a message on Instagram, and we left the users.
Thank you. Thanks for sharing your knowledge and your information. Yeah, thank you.
Thank you.
We are looking forward to seeing you in the next events. Thanks for giving us your time and for your amazing lecture.
Bye.
Bye. Yeah, bye till then. Take your time.
Thanks.